Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet, in our opinion. My name is Bob. I'm exactly one half of the Bob and Brad team, and I'm joined by Mike Keenitz, who is part of the Bob and Brad crew and has a channel in their own right, which covers Bob and Brad products and other products for review. So it is our extreme pleasure today to be, this is really going to be part of our expert series. We're interviewing people that are experts in their field. And today it is a great pleasure to have Dr. Deb, or Deborah Riczo. Did I say that correct? Riczo?
It's Rizzo, like Ritz cracker.
Oh, Ritz. Oh, Rizzo. Okay. Dr. Deb.
Dr. Deb.
Yeah, Dr. Deb, if you'd maybe give just a little bit of your background so people can know who you are in case they aren't familiar with you.
Sure. I am a physical therapist, and I've been a practicing physical therapist for, I hate to say this, but
I know,
4 decades. So I worked for over 30 years at Metro Health Hospital, which is a county hospital, and got an incredible amount of breadth of experience working there, and focused in the last decade on orthopedics, and developed a method that is kind of the thrust of what my work is now, helping women with pelvic girdle and sacroiliac issues. So that's kind of plus in the 90s and the 80s, when people really weren't doing it, I had a business with teaching prenatal and postpartum exercise classes in the community. And I partnered with a couple other therapists. And so that was really fun. And I got to do a lot of program development and actually teaching the exercise classes. So I have a long history of being involved with women's health, specifically the prenatal and postpartum population, but women's health in general. So.
Awesome. And I'm going to just mention, you have 2 books. Do you have more than that? Or I'm familiar?
No, I don't. I started writing when I retired. That's why I retired when I did, so that I could actually, continue my journey.
I've read both of them, believe it or not, and they are excellent books. They're really written for the layperson, although the professional would get something out of it too, believe me. And the first one is called Sacroiliac Pain. That was your first book. And Understanding the Pelvic Girdle Musculoskeletal Method. And the second one is Back and Pelvic Girdle Pain in Pregnancy and Postpartum. Find relief using the Pelvic Girdle Musculoskeletal Method. Now, these are both on Amazon, correct? And OPTP and
yes.
Correct. So awesome. I'll put those back there. Well, we thought today we'd start off with we're going to talk about the sacroiliac pain issues. So I've got some questions that I've come up with. We got some questions that were pulled off from the internet, as far as, was it Facebook?
Yep, Facebook and YouTube, we pulled some questions from.
Sure. So do you want to describe what sacroiliac pain is? I do have a skeleton here. I don't know if you want to. I do have so
sacroiliac. So yeah, you can point to where the sacroiliac joint is.
And here's the sacroiliac joint.
The joint, right? So like if you put your hands on your waist and your thumbs are in the back, your thumbs were going to go kind of right in the area where the sacroiliac joint is. When you have sacroiliac pain, you can think of it as either being localized, like right to that area, but you can also have pain that travels. So you can have pain that travels into the buttock, into the thigh, sometimes even down the leg. And that's why it's confusing, because it can get misdiagnosed as pain coming from the spine when it's not. So that's
generally you would agree that the pain will not travel below the knee. Is that, or
that used to be the thinking, but there has been research that has shown that it can go past the knee.
Oh, no kidding. So now it makes it even tougher yet.
It makes it even more confusing.
Right.
Yes.
Right. So what do you normally use as your assessment tools or assessment I guess what do you use to assess SI pain?
Well, it's a combination of a lot of things to pull in to make the picture. So I look at the mechanism of injury, like when did it start?
Sure.
You know,
Yep.
because a lot of times sacroiliac pain is either a trauma. So someone has fallen, they were in a car accident and they've had their foot on the brake and they had
That jar. Yeah.
that jar, or they stepped into a hole, fell down the stairs. So some type of trauma. If they're pregnant or postpartum, because we know the incidence is higher with pregnancy and postpartum. And then again, did they have this before they were pregnant?
Sure.
So you kind of have to tease that out. And any other, what therapists call comorbidities.
Sure.
So what else is going on medically with them? What other surgeries have they had? So issues like that. And so we put it all together. I put it all together in a picture. And then of course you have to either clinically look at them or virtually.
Sure.
And put the pieces and parts together. So if I was with somebody, I would palpate them to see where they were tender. But if I'm not, I can have them palpate themselves to see where they're tender. And then of course, have them move and see where they're limited in their movements and putting that all together, as well as looking at their pain and the cycles of the pain. So whether the pain is like constant, not relenting, never goes away. I mean, some of these are what we call as therapists red flags, versus it gets better, it gets worse with activity. Kind of putting all these pieces together, as well as any imaging that they may have had done, and then coming up with what therapists call as a diagnosis, a physical therapy diagnosis.
Dr. Deb, do you do compression tests and distraction tests, or I believe it was called Fortin sign, where you take your finger and point?
I love Fortin sign.
Okay.
Yes, I love that. So Fortin was one of the researchers actually that his work showed that the pain can go down past the knee.
Oh, really?
And that was actually, I think, in 2009. So, and the Fortin's test, or if you want to call it a test, is like what you said. You take one finger and then you ask the person where their pain is, most of their pain. And I use that all the time, like even for the shoulder, because then somebody will just point to one spot versus doing something like this. So if they point to an area by their sacrum that is within 3 centimeters by 10 centimeters in a rectangle, that's Fortin's area.
Sure. And then plus, if it's replicated, right, they can hit it and then they come back and hit it again. Is that right? I don't know if that's part of the test or not, but so with SI pain, what do you think is normally going on? Is it laxity, tightness, weakness, or possibly all above? Do you feel it's the joint itself, or?
Yes.
Now, I from your book, you were really a big believer, though, that things get out of place, as they say.
We don't have a lot of evidence to be telling people that they're out of a joint or out of alignment.
Sure.
We just don't. So I don't, and I used to do that.
You don't go down
until I really started getting into the research, into the literature, and looking that we are probably doing a disservice, because number one, the SI joint does not really move very much at all. It's minuscule and it's really bound down by a lot of ligaments. But what does, it's not that it's not painful, and it may feel like it's out of joint, but what often is causing it to feel like that is muscles are too tight on one side and too loose on the other, and it's causing a pull that is pulling on the bone and the tendons and causing inflammation in the area. And when something gets inflamed, then we know inflammation causes pain.
Gotcha. Yeah.
So
I believe Dr. James Siriax didn't even believe that SI was a problem because it was such a stable joint. But that's neither here nor there. But So this kind of answers my next question. Now, one of your first self-assessment tools you have for people is to actually palpate or feel the bony prominences. And you have to get the book to have this explained better. But so the ASIS and the PSIS, sorry, I got it. And then also in the pubic region. So I'm assuming that'd be muscles that are tight and have made that area tender.
Correct. Correct.
So now you have it, if it's found on one side and not found on the other, you feel there's an imbalance in the pelvis.
Correct. So those bony landmarks that you just pointed to would be a sign that you are having something going on that's not normal on that side versus the other side. Just like if you had a sprained ankle and you were touching the bones on your ankle and the ligaments that are attaching to it, and then you could have swelling there. So it's really not any different.
Gotcha. So I'm just a little confused because you don't go behind the scenes and explain it from a therapist standpoint, and it's for the layperson. But you have people. Your exercise number one is if they have tenderness on one side, you have them lift up one leg, and you push against that leg, and the other leg is kind of bridging. Again, you'll have to check out the book to see this, but you do it on one side no matter what issue is going on, right? I mean,
yes.
No matter what side the tenderness is on.
Right.
Can you explain a little bit what's going on?
Well, that's based on that our bodies are not, our bodies look symmetrical, like we have two arms and two legs, and everything's looks symmetrical, but on the inside we have different weight distributions. And because of that, and really they don't really know why, but we have certain patterns that happen in our body. Scoliosis occurs usually always with the right thoracic, left.
Oh, interesting.
Lumbar. So the patterns that are found are why the exercise is only done on one side. And I have been using the method since 2008, and then started teaching the method in 2011. I went back to get my doctorate, and I used this method that I was using in the clinic because I started getting people referring to me. Doctors were wanting their patients to be seen by me. Therapists were coming to me. I'm like, well, I think I developed something here just because of my clinical practice. And so I wanted to, I went back to school, I got into the literature, and then I, not published, but I wrote a paper that then I started using for school, that I started using as the basis to develop a course that I started teaching to therapists. So that's kind of how it evolved, because I was seeing so many people, even that were seen by other therapists, and there wasn't a cohesive approach out there. Everybody was doing something a little bit different. And if you have a certain frame of mind that you're out of alignment, you have to get fixed, that's very different than having some exercises at your disposal that you can have and help yourself if you run into problems, and then a strengthening program to prevent you from running into problems.
Gotcha. Yeah. Thank you for explaining that. Mike, we want to show the picture real quick. I don't know if you can catch that. So that's the exercise we were talking about. And, on exercise number 2, it seems like is that more for the pubic ramus area, or is that, what are you trying to accomplish with that? Do you want to show that one?
So the first exercise, not everybody needs to do that has sacroiliac problems. So that's why it's hard I don't want people to think that they should try that first exercise, because if they don't have those signs then they still can have a sacroiliac problem. They just don't need to do that exercise.
And you explained that well.
That exercise is actually working on the component of the muscles that are tight this way, like this way on your body. And so then the second exercise is to address the muscles that are tight this way, our
Gotcha.
side muscles.
Gotcha.
So that's why everyone doesn't have, that's why the method is a step-by-step approach that if you follow step 1, step 2, step 3, then it'll be the right thing for you.
Gotcha. With I'm sorry to keep asking you about all these because I'm just curious from a professional standpoint.
One by one.
This exercise too. That's exercise number 3. Your daughter is very beautiful, by the way.
Oh, yes, she is, isn't she? Thank you.
So that exercise, what are you trying to accomplish with that exercise, or what is that accomplishing?
So that exercise, when you're sitting tall and you have your one leg out, we're sitting perched right on our sit bones.
Sure.
Okay. So when we're sitting, if you're sitting correctly, we're sitting right on our sit bones. So we're trapping the sacrum if we're sitting tall and not slumped. And then when we put our one leg out, we're stretching the rotators on that side, which have an intimate relationship with the workings of the pelvis. So then when we're turning, we're affecting all the small little muscles and the larger muscles and all the ligaments that are in the pelvic area, the sacral area, that may be the culprits.
Gotcha.
So what I have found is that when people do this, they're generally always tighter on one side versus the other.
Is it generally the painful side, or is it does that?
Yeah, well, yes. I always have them start on the non-painful side so that they can feel what normal feels like. And then it's important to do deep breathing with this, and just breathing, because you don't want to be tense with any of these. Because if you're tense when you're doing any of the exercises, then you're going to be preventing the natural movement that should be occurring.
Good. Actually, that leads me to another question I had is about breathing. What do you feel the role of breathing is in pain control and treatments? I mean, do you spend a fair amount of time on that with people, or what are your
It's
thoughts?
the number one thing for the mind-body connection. And if people are having a disconnect there, it's going to be really vitally important. It's going to be more important for some people than other people who might be already in tune to that. But for a lot of people, especially that are in chronic pain, their pain can be dialed down quite a bit if their anxiety and their fear and some of these other things can be dialed down, because we have, 2 systems in our body. We have a fight or flight system that revs us up, and then we have the system that calms us down. Well, the breathing gets us to connect to the system that calms us down, and we all need that during the day. I think. I mean, I need that during the day. I have my little I watch, and it tells me to stop and breathe. And sometimes I find myself saying, I don't have time to do this. And I'm like, oh my gosh, what am I saying? Because I'm a little bit of a type A personality. I don't know if you can tell. So I need to do deep breathing because I need to connect. And if you're in chronic pain, it's very important because we tend to tense up when we're in chronic pain, or even not chronic, even just acute pain.
Yeah, or just normal life. I mean,
right.
So it's been interesting. We'll have to maybe have a conversation on this sometime. So I've been heavy into this breathing thing right now. And
yes, he has.
Yes, yeah. And so the big thing that I'm a mouth breather, which is kind of a negative connotation, of course, but it has made such a difference that I've been working on breathing through my nose. And I've seen now studies that have shown that it decreases blood pressure, which it has on mine. It decreases stress. I sleep better. It's been amazing to me. I mean, it's been life transforming for me. So I don't know if you read anything on that or not, but
absolutely. In fact, this is recent for me too. I have been starting to do my treadmill workouts with my mouth closed.
That's what I'm doing.
Oh, really?
I'm trying to run.
It's much harder.
Yeah, it is.
Much harder.
It is. Oh, that's great that you're in the same area.
But so the whole idea is that when you are under stress, that you when you're on the treadmill, and that's like you're starting to increase your workload,
Sure.
that you connect your mind with your breath, so that you are using your diaphragm when you're breathing instead of doing all this upper chest and
Sure.
like that. So that if you keep your mouth closed and focus on the breathing, your body is going to metabolize what it needs as far as oxygen and carbon dioxide in a more efficient way.
Yeah, it's not to be belittled. I'll tell you.
Yeah.
Well, the other thing where we discovered is my wife, when we have 3 children, and the first child, for some reason, we didn't buy into the breathing Lamaze and stuff. And oh my God, the second time was such a reduction in pain and management by just performing the breathing exercises they recommend. So
And actually, unfortunately, there's a lot of people that don't value childbirth classes.
right.
And so they're even missing that education. So yeah, absolutely.
Our lodge. Yeah. So, all right. I see you incorporate some pain neuroscience education in your book. Can you tell us how you approach that with your patients, or you did with your patients or the consumer? Or
Yes, the concept is that, we feel pain, generally acute pain, by, touching a stove, and it comes up to our brain, and that's, we feel the pain. But the perception of pain actually is being registered in the brain. So if you are having pain for a long time, it's been proven, if it's over, I think it's like 3 months, it actually gets processed in a different center in our brain. It's not so much where it came in or where the injury, because there's different places that map out to the brain compared to on your skin. So the processing occurs more in our emotional area. And that's why people can have such pain with just clothing touching, because it's being processed in a different part of the brain. So the analogies work great here. So it would be not paying attention, not actually waiting for the next pain, but doing breathing and not being fearful. So the analogy that I like to use is, if you were walking in your house, being relaxed and comfortable, and then you were walking in your house thinking there was an intruder in there somewhere, and you're looking behind you and you're just like this because you're just so fearful. So people feel like there's an intruder, or there's something bad inside of their bodies, and they're trying to run away from it, and that causes a lot more tension and stress, versus knowing that the pain is there and just trying to de-stress and not make it mean more than what it is.
sure, that's a great example, by the way.
Yeah.
That works out really good. This is a Facebook question. What's the importance of posture in helping with sacroiliac pain?
It's got a huge role. I talk a lot about because people end up doing things out of habit that they don't even realize can be feeding into the problem. For example, even the way they carry things. A lot of times women will carry like their children always on that right hip,
Yeah.
or always on that left hip. So if you keep doing things over time the same way, you're going to get tightening of certain muscles on the side you're carrying if you're shifting that hip over, or even if you're just standing on one leg all the time. Like people will be standing and they'll stand shifted all the way over to that right side all the time.
Yep.
And so that plays a significant role in what is spilling out that we're seeing.
And for me, it's I tend to sit on one side. I don't know why, but I have to constantly, remind myself.
Sitting is huge because we sit a lot now, don't we?
Yes, we do way too much. So, yeah. All right. There was one last question on the SI. How do you decide if an SI belt is appropriate? And is there a certain type you would recommend? That was a Facebook question too.
That was a mic question.
Oh, that was a mic question. Oh.
Sacroiliac belts can be extremely helpful with this population with having sacroiliac pain. if you feel good when you have you can take a regular belt and put it on below your hip line
Sure.
and give that compression. And if that feels good when you're walking, then you probably would benefit from it. That's probably the easiest way I can tell you, like a thicker belt, like a man's belt
Gotcha.
down low, or like those hip hugger belts that we used to wear. You can even get a little bit of a sense if you take your hands, put them on your hips and push, put them this way and push into the joints while you're walking. So you're kind of pushing right in while you're walking.
You're pushing this way.
No, more like, hold on, let me get my pelvis.
Oh, here we go. Oh, here we go. You just got a better pelvis
Yeah,
than
yours
we do.
better than ours.
Okay, so if you push in this way, your hands like this, not here, because this might actually flare it out,
That might actually distracted.
but you need to push it in this way.
Well, now I'm embarrassed because I've been doing it wrong. No, I have. Brian Mulligan would recommend that you walk behind the patient and, push along to see if it helps. But I was always.
But if I'm behind a patient, I'll put my hands like this and push in with my thumbs. Because you want the pressure going toward the joint.
Makes complete sense. I was doing it wrong. Sorry. So, is there anything else you want to add about SI pain that I know we didn't cover everything, but I thought that was a good introduction for everybody.
I teach a full day course on
right.
Sacroiliac and pelvic girdle pain. So no, we didn't cover everything.
No, not even close. Right.
Yeah.
Thank you for your expertise on that. But
you're welcome.
Would it be okay if we talk about the pelvic girdle pain a little bit?
Sure.
Okay. So I saw from your book that this is really common. You want me to give the stats or?
Sure.
So during pregnancy, up to 56 to 72% of the women can feel pelvic girdle pain. And I thought what was more distressing was that 7 to 25% can have continued pain afterwards. So that is a large part of the population that have.
Yeah.
So,
yes. And then that affects, it affects their quality of life.
Oh, absolutely.
And it affects their relationships. It affects what they can do with their children and with their husband. It affects their livelihood. Sometimes when they go on disability. Anxiety and depression have been widely associated with chronic pain. So there's all kinds of really not good sequelae for not having a good treatment, and that's why I do what I'm doing.
Sure.
So that we can try to help as many people as possible, specifically women, because most of the research has been done on women prenatally and postpartum for pelvic girdle pain, because that's the population that it affects the most. And I know that when I am treating a woman in menopause, often she'll tell me her first time when she had pain was during her prenatal or postpartum period. And then it may go away, but then it comes back, and it just really never goes away.
Oh, good Lord.
Because they haven't addressed all the pieces and parts as far as their flexibility and their strength and their function and how they're moving to have it, to really be gone.
Sure. So I know our recommendation would be to check out this book. Well, I'd say this one actually, for back and pelvic girdle pain in pregnancy and postpartum. Now, I think this is a great starting point. Some people will probably alleviate their pain just by doing the self-treatments in here. But where would they find a PT, a physical therapist that is expert in this area?
The American Physical Therapy Association has a section called pelvic health. And so those are the therapists that are really specialized in working with areas of the pelvis and any type of pelvic pain, pelvic girdle pain and pelvic pain. So
if you go to their website,
you can go to their website, it's APTA pelvichealth.org, and they have a Find a APT
Oh, awesome.
tab. I am also going to be rolling out, because I just launched my new website yesterday, but I'm going to be rolling out a PT section for therapists that have taken my course.
Oh, fantastic.
I have a 1-day course. I used to actually teach a 2-day course, but now it's a 1-day course and it's virtual. And I'm going to be rolling out that section, and I'm going to contact people that have taken my course over the years and see if they want to be on that list, so that there will be reference for people literally. Now that it's virtual, it'll be for people literally all over. So that's coming. I haven't done that yet.
Okay, so that, yeah, and you can see her website was listed behind her, over her right shoulder, left shoulder, different how you're looking at her, but okay.
So I went like this.
Do you mind if I ask, what kind of success rate have you had with SI and pelvic girdle pain? I mean, do you have a sense of what, I mean, obviously you were doing quite well, because whenever people start finding the guru and start sending people to them, there's a reason. I mean, people are getting better. So, but
yes, I mean, I really, as long as people are compliant, that was the biggest thing, because sometimes people, so here's the thing, sometimes people feel better and then they don't do the whole
they stop
package, So I don't have a hard number for you, because I haven't actually taken statistics, but the vast majority respond to this treatment. I mean, I even there's reviews on Amazon that of people that have had pain that I don't know and I've never touched, but people that have been through practitioners or have had pain for a number of years, and they are getting relief. So to me, that's why I keep going, because I know that this technique, this approach, it's an approach which is a holistic approach. Like you cannot not get that mind-body connection, connect with your breathing, and do all that work and just do the exercises and then be real tensed up when you're doing them and like, oh, these don't work. It's a package. And then being aware of what you're doing during the day, how you're sitting, how you're carrying things. It's really, the whole method is all those things. And these specific exercises too.
Yeah, and it's very comprehensive. I mean, it goes through the pregnancy and also afterwards, and a lot of stretches. And I think you emphasize with some of the stretches towards the end of the book, you don't necessarily have to do every one, or you certainly don't even have to do it on both sides. If you find one side is tight, you might want to focus on that side, and if vice versa. So
right. And so the other thing I wanted to mention, Bob, is that these exercises are meant to be simple. They're meant to be, I call them remedial. So they're the first stepping stone to kind of get you going.
Sure.
And so they're not meant for that you need to do these for the rest of your life. They're meant that these are to get you where you want to go, where you want to be. If you want to get back to a sport that you were doing, or if you wanted to, go hiking for your exercise, that's where you want to go. You want to do things that you enjoy, but you want to have these are stepping stones.
Gotcha. Can you talk about the importance of strengthening the pelvic floor? It's interesting because I had read a book with the Kegels and stuff like that. And in their approach, they were really trying to have you focus on the pelvic floor alone and not the muscles around it. And it seems to be on your approach that you're wanting to like engage them at the same time. Am I wrong? Am I?
No, that's a very good observation. So there is a place for just doing the pelvic floor contraction. There is a place for that. And that is when women are having more specific issues with incontinence, pelvic organ prolapse, which is a common condition after pregnancy, and painful sex. So when you're having some of these issues, that's where the pelvic health therapist will come in, and they will actually evaluate the pelvic floor and then work on you getting a control back. Because see, those systems work automatically.
Mhm.
And so if that automatic piece isn't working great, that's when they need to kind of work with that to try to get that system working properly. I incorporate the pelvic floor in the exercises because they normally would come in when you exhale. So it's just kind of bringing an awareness there. But if when you are exhaling and you pull your pelvic floor in, when you're breathing back in, that pelvic floor should relax down.
Gotcha.
So it should be doing this. And if it's only doing this, then we have a problem, Houston.
Right. If it's tightened all the time.
Yeah.
Yeah. Hypertone. Yeah. And that's exactly what you said. It was the case where it was for people that were having trouble with, bladder problems and such. It wasn't other issues. It wasn't pain, except like you said, maybe with sex, but, so thank you for clarifying that. When do you, recommend the use of compression? This is a Facebook question. Was it yours?
No, it's mine.
Your question?
Those are all my questions.
Oh, when would you recommend compression pants, or maybe even the like maternity support?
I think that maternity supports will probably make most women feel more comfortable in that last trimester. Specifically, if someone's walking around and they're always holding their belly. Yeah, I don't know if you've been around many pregnant
Yeah, I've seen that.
women hold their belly. They for sure. That's a sign, because the abdominals are so stretched. They can only stretch so much, and that little bit of support helps. So in that last trimester, I think a lot of women would benefit. Financially, it's an issue because they're not, it would just be something else to do. But if you find that you're holding yourself like that, you're holding your belly a lot, you would benefit from a maternity support. And I know that some women would also benefit from the sacroiliac belt, just because the joints are just getting looser and that compression. Now, I didn't say this before, so I'm glad I had this opportunity, because I've anyway. So if you put on a sacroiliac belt and it makes you feel worse, it's a very good chance that you need to do the pelvic balancing exercises that I prescribe and get that balanced, and then put it back on. And then that works 9 out of 10 times. I haven't really seen that not work.
It makes complete sense.
Yeah.
Is there a time when compression pants are appropriate, or?
Oh yeah, a lot of women find a lot of support postpartum as well to having a compression pant. There is a compression pant out there that has a sacroiliac reinforced area around the sacroiliac area, and that is Supercore, and they're based out of Australia. And the reason I know is because they had contacted me to work with them, and then the pandemic hit. So they are looking to come into the United States and have a distributor and things like that. But they are advertising on Facebook and social media. I've seen their ads, but the product would actually be shipped from Australia.
Gotcha.
Called Supercore. Yeah.
Is this probably two?
They're all mine.
All right. How important is diet when it comes to pain management?
Well, you know that what we eat can influence inflammation.
Right.
There is actually called an anti-inflammatory diet, and you can find information on this diet on the Arthritis Foundation website. It's also known as the Mediterranean diet. So if we're eating a diet that causes more inflammation, then we're setting ourselves up for having more inflammation.
Right.
And that's why you take medication. Some people take medication is for that anti-inflammatory effect. And so if you can, diet's important.
Gotcha.
To answer your question.
Really anti-inflammatory type.
Yes.
Yeah.
Yes.
A lot of plant-based, quite often, Mike.
Well, meat doesn't cause inflammation.
Yeah. Okay. All right. Well, anyway, we just kind of got the tip of the iceberg there, maybe on pelvic girdle pain, and you're going to do a lot better if you check out the book.
Yeah.
Again, back and pelvic girdle pain in pregnancy and postpartum by Dr. Deborah Riczo. Rizzo. Yeah, there we go.
You also did a write-up on our blog.
Oh, yeah. Thank you very much for doing that, by the way.
If people just want to see a little short excerpt of a lot of these things, it's on there too before they buy the book. Like they could check that out as well.
Yeah, we'll put a link for that.
And I should have mentioned earlier that OPTP is running a 20% discount on the book.
Oh, great.
To help me celebrate my new website. So you just would go to my website and there'll be a banner at the top saying 20% off, and then you'll get a code. I'll send you a code, and you can get it for 20% off through the end of March, and then the sale goes away. And it's not an expensive book. It really
No,
isn't.
it's not. In fact, I don't know if you knew this, Dr. Deb. The way I found out about you is, we have some products through OPTP too. And their president had told me, or CEO had told me that she put they did an email blast of your first book, the SI book. That it was the best response they've ever had to a book.
Really?
Yeah, she maybe didn't tell you that, huh?
No.
Yeah, it was. I'm like, well, I want that book then. So that's when they sent it to me, and
these are nice for your average consumer too, I'd say. Because this book is 36 pages. It's
Right.
not like a heavy, dense textbook. Your pregnancy one's more. It's like 100.
It's more
pages,
comprehensive, yeah.
A little more comprehensive, but it's very easy reading, and there's lots of diagrams of how to do everything properly. So,
all right. And again, I don't know if there's anything you want to add. I'm sure this is, again, part of the long course that you were doing, but I would like to just take maybe 5 minutes to go over. These are going to be questions more geared towards a physical therapist that would want to hear the answers. Would that be all right, Dr.?
Sure.
Okay. So, did you have mentors? Do you have work that you follow? Who influenced you in your area of expertise?
Well, when I was working at Metro, I was always going to the same therapist to kind of pick his brain regarding muscle energy techniques.
Sure.
And his name is Tom Oakler, and he actually teaches his techniques that are based all on muscle energy. So he was really my mentor. I had taken a lot of continuing education courses over the years. We need to take them for our license.
Yes.
And I was always taking them in the manual therapy. I was wearing that label, and women's health. So there were a lot of gurus that had been teaching at that time. Elizabeth Noble was one of them, who was really big in the prenatal and the postpartum exercises. So,
yeah, that's good. This one's going to be a little bit of a curveball. What are some of the bad recommendations you hear in your profession or area of expertise? Are there any that stick out?
Bad recommendations?
Yeah, like what if you see other therapists recommending something to women with girdle pain, and also pelvic girdle pain, or also SI? Is there bad recommendations that you see that you?
Well, I think that, and this is something that I had to break myself of, that we're teaching people that when we talked about this earlier, that they can be out of alignment, and
Right.
that they need to be corrected. And people have that mentation as far as going to chiropractor,
Yes.
that they need to be adjusted. And
Yep.
in my mind, if you are going to the same person for years and getting the same thing, we got to do something different.
Right.
I've had people come to me this one woman not that long ago, she was telling me how she went through 3 different therapists that either moved or retired, and she was devastated.
Right.
Because she couldn't go back and get her adjustment.
Yeah.
So that's what I think as
I
a
agree
profession, we
100%.
need to give people tools and to empower them to be in charge of their kingdom.
Gotcha.
Their kingdom.
I couldn't agree with you more. We're creating dependent, patients.
And be advocates for themselves when
Yeah.
they are dealing with a healthcare provider, to do some homework and to make sure you're doing homework in the right places, not just anywhere on the internet. That's a
Sure.
problem too.
Yeah. So you mentioned the muscle energy. Did you try any other approaches before you came upon your
I
method?
was very, very good with muscle energy.
Oh, you were.
I was hands-on. I was putting people in those pretzel positions, having them do this with a pound of pressure and move it down and move it up. I did a lot of strain, counter strain. I did a lot of stuff as far as manual therapy. And what was happening was that where I worked was a very fast-paced clinic. And I started streamlining the process, and then it just kind of, I was really, you learn from each patient that you see.
Right.
And if you really think about what you're doing and critically look at somebody 3D so that you can see the muscles and the joints, and then you're starting to get a different picture if you just are looking through that lens, I think.
Yeah.
And your practice evolves. You practice differently now than you did 5 years ago, hopefully.
Exactly.
Yeah.
Dr. Shiaks, again, going back to him, he was a big believer in that you're constantly reassessing, and don't be afraid to, the standards that you're afraid to go against them. And that was one of my questions. I mean, your creative process for developing new ideas, and it sounds like you kind of explained that.
And the other thing is that I really use the patient. How does that feel? Does this feel tighter? How did that exercise feel? I want to know, because they're the best thing for feedback to me, is to have that dialogue, because I might think that range of motion looks fine, but if they're telling me it's tight, I'm not going to, judge my eyeballs versus what it feels like to them.
Sure.
That's more the real deal.
Yeah, that's a sign of a very good clinician. So, now we're going to have ways for people to contact you. And you said you are still doing continuing education courses for therapy.
Yes, I have a course coming up March. I want to say it's March 16th. It's listed on the American APTA Pelvic Health.org website under their continuing education. And it'll be on my website too. The link to the courses that I teach are on my website under professionals.
Sure.
And I also do shorter courses with motivations CEU.
Oh yeah, yep, exactly.
Yeah, I do a shorter course for them, and there's a course coming up in April for them.
In some sense,
and
go ahead.
And I'm rolling out a 12 series course with Physiopedia.
Oh, nice.
Yeah, and that's all on pelvic girdle and sacroiliac pain, and those are 12 different courses.
Well, the only good thing about COVID, and if there's anything good, it was, that you don't have to travel as much now. I'm sure it's all virtual, and more people have access to you then for that reason.
Right.
So,
right.
I'll just finish with this. Do you have anything new coming up? Are you exploring any new areas or any new theories, or are you pretty happy with where you're at?
So my mission is to get this information out on as many platforms as possible. And I really appreciate this opportunity, because I know you
likewise
have an incredible platform. And so, that's what I want to do. And that's why I redid my website, because I'm going to be putting things on there that hopefully can help women, especially women, just because this is where this occurs. Although I've treated plenty of men, and it does work with men also. But my new thing, if you want to know, is I'm going to try to be partnering. I'm going to be partnering with nonprofits that service women that may not have access to physical therapy, and that may not be the focus of what that nonprofit is for.
Sure.
The nonprofit might be more concerned about, other social things that are important for this person. and not necessarily these issues which they may be dealing with.
But as you said, that overflows to everything else, like you said.
Right, right. So I'm going to try to make this a platform for outreach and to be inclusive.
Well, thanks again for all the information. Again, one more time, please check out the books. We'll have them linked below. Excellent books. Thank you so much for taking the time, and I'm hoping we can maybe do something like this again. So
I would love to.
all right, thanks, Dr. Deb.
Thank you. Thank you so much, Mike and Pat.